evaluate a physical examination on a preterm infant. This session will be carried out without interruption and in a more realistic sequence. The maneuvers requiring the infant to be quiet will be performed first. This is a 14-day-old, 33-week gestational age male infant. He was delivered prematurely, secondary to a suspicion of chorioamnionitis and intrauterine growth retardation. His neonatal problems included mild hyaline membrane disease, hypotension, and hyperbilirubinemia. He is now a stable, growing, premature infant and weighs 1,450 grams. We will begin the examination with a brief observation period, noting color, perfusion, state of alertness, overall posture, and degree of extremity flexion as an indicator of tone. This infant is pink, well perfused, with a normal capillary refill. His overall posture is semi-flexed, demonstrating a moderate degree of tone, which is appropriate for his gestational age. The infant is alert and able to fixate on and follow an object for a brief period of time. To evaluate the cardiovascular and respiratory system, the examiner will begin by observing the chest and precordium, noting the point of maximal impulse if visible. The precordium is palpated next. Then the heart and lung sounds are auscultated. The stethoscope is briefly warmed with the examiner's hands. The examiner assesses the 4 primary areas: the aortic, which is located at the upper right sternal border; the pulmonic, which is located at the upper left sternal border; the tricuspid, which is located at the 4th intercostal space along the left sternal border; and the mitral area, which is located at the 5th intercostal space along the midclavicular line. Additional areas to auscultate include the infraclavicular and axillary areas, the right side of the chest, and the back. During auscultation, the examiner notes the general heart rate and the quality of the first and second heart sounds, as well as any extra or abnormal sounds. The area over the anterior fontanelle and liver are also assessed for bruise. There are no murmurs auscultated, the heart rate is 150, and the S1 and S2 are normal. The lungs are auscultated next, proceeding in a side-to-side fashion and over the back. The lung sounds in this infant are clear and equal, with a respiratory rate of approximately 40 breaths per minute. The brachial, femoral, and pedal pulses are palpated next. The brachial and femoral pulses are palpated simultaneously and compared. The pulses in this infant would be described as 1+. To inspect the abdomen, the examiner observes the abdominal movements and shape. This abdomen is slightly rounded and full. There is no evidence of a diastasis recti. The umbilical area is inspected. Since this neonate is 14 days old, the cord has fallen off with a clean umbilical area noted. The examiner listens to all 4 quadrants of the abdomen for bowel sounds. Bowel sounds are audible in all 4 quadrants in this infant. Generalized palpation of the abdomen is performed next. All 4 quadrants are palpated. The knees are flexed if the infant tenses his abdomen. The liver is palpated on the right, beginning with light palpation in the lower right quadrant. This liver edge is felt at approximately 2 centimeters below the right costal margin. The spleen is palpated on the left using the same technique. The spleen is not palpated in this neonate. Both kidneys are palpated using the bimanual technique. One hand is placed under the flank of the infant, and the other hand palpates over the flank. The lower pole of both kidneys may be palpated. At this time, the practitioner has completed most of the components of the exam requiring that the infant be quiet. She then moves to evaluate the infant in a head-to-toe sequence, skipping the areas already examined. The practitioner takes the head in her hands and inspects and palpates the full circumference of the head. The coronal, sagittal, and lambdoidal sutures are palpated. The anterior fontanelle is assessed for size and fullness. The posterior fontanelle is palpated as well. The face is examined next for shape, symmetry, and lesions. The eyes are examined for placement and palpebral fissure size. The eyes are opened manually to inspect the sclera and iris. The examiner next assesses pupillary reaction and presence of the red reflex using the ophthalmoscope. The ears are inspected for form, shape, and anomalies. The position of the ear to the eye occiput line is evaluated. The ear position is normal in this infant because it falls within the eye occiput line. The nose and nares are inspected. There is no flaring or septal deviation. Patency of the nasal passages is assessed by occluding one nares while auscultating for air sounds from the other. For accurate assessment, the mouth should be closed during this procedure. Using a tongue blade and a light source, the examiner probes the lips and gums of the neonate. The inside of the mouth is inspected. The rooting reflex may be elicited next along with the suck reflex. The neck is inspected and palpated. Lateral and vertical range of motion are then assessed by rotating and flexing the head. The area of the thyroid gland is palpated next. Moving to the chest area, the clavicles are palpated along their full length. The ribs and the sternum are palpated while inspecting the chest for lesions. The nipples and breast tissue are inspected and palpated. This neonate has very little breast tissue due to his gestational age. Finally, the chest circumference is measured. Since the examiner is inspecting the chest, it is most efficient to complete the examination of the upper body at this time. The arms are palpated and the range of motion of the shoulder, elbows, and wrists are evaluated. The axillary area is inspected. The hands, digits, and nails are also inspected and palpated. At this time, spontaneous arm flexion and recoil are assessed. Finally, the grasp reflex may be elicited at this time. Since the abdomen has already been evaluated, the genitalia and anus are examined next. The penis is inspected and the foreskin is retracted. The meatus is properly located at the tip of the penis. Both testicles are descended and are palpated high in the scrotum. The anus is inspected along with noting whether the infant has stooled. At this time, the lower extremities are evaluated. Movement of the legs is random and symmetrical. The legs are inspected for symmetry in length and skin folds. The legs are palpated and the knee and ankle joints are assessed for range of motion. The feet and toes are normal without evidence of metatarsus adductus. Assessment of clonus may be carried out next. 3 to 5 beats of clonus are expected in this infant. The patellar jerk reflex may be elicited at this time, although the response varies with the gestational age and the state of the baby. To examine the hips, the practitioner evaluates one hip at a time, performing the Barlow's maneuver first, followed by the Ortolani maneuver. Then both hips are evaluated simultaneously. There is no evidence of subluxation or dislocation in this neonate. Throughout the examination, the practitioner has observed changes in the neonate state, general tone, and symmetry of movements, along with skin color and any abnormal lesions. To complete the evaluation of the skin, the practitioner inspects the skin thoroughly on the front and back. While the baby is on his abdomen, the back is inspected. The full length of the spine is inspected and palpated. If the lung and heart sounds have not already been auscultated on the back, they may be auscultated at this time. The baby may then be held in ventral suspension to evaluate neck extension and strength of the spine. The truncal incurvation reflex may be assessed as well. At this point, most of the exam has been completed with the exception of a few neurologic components. The Moro reflex in this neonate is evaluated by a flexion and quick drop of the head. Note the brisk and symmetrical outflinging of the arms. The preterm neonate may lack the strength to bring the arms back to the center. The neck extensors and flexors are assessed in the pull to sit maneuver. The neonate is pulled to a sitting position by traction on the arms. Support is given to the shoulders of this preterm neonate. A significant amount of head lag is noted in this neonate, which is to be expected given his prematurity. This completes the examination of this neonate. Physical examination of the newborn requires well-developed observation skills on the part of the practitioner as well as an opportunistic approach. The state of the baby will significantly impact your interpretation of the examination and your ability to complete it adequately. Multiple evaluations over time may be the most effective means of fully evaluating the newborn, particularly since significant physiologic changes are occurring as the neonate makes the transition from an intrauterine to an extrauterine environment.